Pharmacy Federation. So for today's presentation, today is a research category. So for today's presentation, I'm happy to introduce Dr. Tahur Gurjit Singh, Associate Dean from Chitakara University, Punjab. Ms. Rituraj Gaur, Principal, Aishwarya College of Pharmacy, Rajasthan. And Dr. B. Wilson, Dayananda Sagar University, Bangalore. So we'll welcome you all. So over to Chavi to continue.
Good evening to all the evaluators, and thank you, Dr. Kainrajan, for starting the poster presentation for 7-day and all the participants. So I would request all the participants and evaluators to switch on their camera when they are speaking and a good internet connectivity. If you're not having a good internet connection, then you will be given a chance at the end. Next participant is eNest 437. Enes 437, are you ready to present?
I'm ready. Thank you.
So I'll just share my.
Yeah, I can.
Please go ahead.
That's fine. Can I start?
Yeah, sure. Please go ahead.
You can start.
So, yeah, good evening to one and all present, to the respective panel and all the participants. Myself from Mysore, and I'm a PhD scholar and under the guidance of Dr. M. Ramesh. And actually, I'm working as a part of a project of assessment and implementation of antibiotic stewardship program in the surgical department. So this was my area of interest, because I saw a lot of antibiotics being used, and it was much of inappropriateness seen. So if we try to impose a stewardship immediately as a part of NABH, we know it is a requirement, but it would not be a voluntary participation from the surgeons. So I thought of taking up the problem from the ground level, wherein we see the drug-related problems. And when we detect such drug-related problems and give suggestions with discussion, we could do the optimization of the therapy. And that would be a stepping stone for initiation of an antibiotic stewardship program. So one of my steps was to find the drug-related problem. So why do we have to emphasize on the drug-related problems specific to antibiotic therapy is today's question. Antimicrobial resistance is a great global hazard all over, and it has been even used in cattle and animals, and not only in humans. So approximately half to 1/3 of the inpatients of the hospital are on antibiotics. And most of them, if we see, it is a suboptimal use that can be seen. So according to the CDC, the Central of Disease Control and Prevention, says that around 2 million people die off every year in US because of the diseases affected because of the resistant pathogens. And by 2050, they expect around 10 million to die off because of such a condition. And in India, the scenario is going to be in 2050, we are going to expect around 2 million deaths because of diseases because of the resistant strains. So coming to the materials and methods, this was a prospective interventional study, and it was of a period of 9 months, which was done in the general surgery wards of a tertiary care hospital. Every day, all the patients who were admitted in surgery were reviewed on a daily basis, and the patients who had at least one antibiotic and who stayed in for at least 1 day was taken into the study, okay, with an informed consent from them. And all the information pertaining to the patient, especially to the patient's medical history and the antibiotic, the dose, frequency, and duration was taken into consideration, the category of use and indication. So category of use, mostly we emphasize on prophylaxis, empirical therapy, and definitive therapy. And what we did is we classified the drug-related problems that we found in the files according to the heparin strand. So we found few drug-related problems that were out of heparin strand, and we tried to enlist it based on a separate criteria based on the evidence from medical literature and clinical practice, which you could see in the table which is denoted, which I would be explaining later. And it doesn't stop with just observing the drug-related problem. Myself, the clinical pharmacist, goes to the surgeon by in person to each surgeon. So actually we have 6 units, and during this period we have 1266 patients admitted, and when we analyzed, we saw that 414 patients had drug related problems, and in this 414 at least one DRP was identified in the patient. So I had to go to the surgeon, tell him about this, and I had to discuss with him, and according to what his viewpoint is too, we had to take a decision. And coming to the results and discussion, a total of 441 DRPs was identified, and we saw that improper duration of drug use was seen the most, which rounded off to 20.86%, and which was the common DRP identified. So why do we see prolonged use is all about when you give an attention to the surgical wards, because we know that most of the patients who were enrolled into the study, and because it was a surgery department, had undergone the surgery. Around 60% had undergone. And we start the antibiotic with prophylaxis, and even though the guidelines say that we have to give it within half an hour to 1 hour before the surgery, and we can stop it within 24 hours, the fear of surgical site infections, it may be not because of the procedures that is conducted, because always breach formation doesn't happen and it is not a contaminated surgery, but still the surgeons have a fear of how well there are limitations for a developing country to have a well sterile OT, and the shifts of the patient and how well can we sterilize the same, and the autoclaving too. It's not because everywhere it's not a 100% procedure that happens everywhere, that can be errors. So for the same thing, that was the justification given by them. But as I said, the drug related problem, wherein we see the duration of drug use is used so much, that itself can cause a drug resistance, which was told to them along with the statistics that I just enumerated during the introduction. So let us just see the categories of the DRPs. According to the Hepler and Strand classification, we see that improper drug selection was around 14.29%, wherein what happens is, because of the prophylaxis, we always tend to give a broad spectrum antibiotic, and mostly we tend to give a third generation cephalosporin. But that was not necessary in if it's not an infected case, but to ensure the good coverage and to protect the patient from further infection, the same was given. And we ensured the surgeon that we could even go with first generation and second generation cephalosporins if it was not a contaminated case. And drug use without indication, again, if a patient had a thyroid surgery and then it continues for the next day, and then they just fear of the infection, so it was not actually indicated in the patient. And subtherapeutic dose, meaning when you have, for example, piperacillin tazobactam should be given thrice daily, so sometimes it was given twice, was seen, because usually every dosing is done twice, so it happens. And adverse drug reactions also was seen to 4.76, and overdose was seen in 14 patients, coming to 3.18%, wherein we have a lot of patients with diabetic foot, especially in the surgical department. And most of them, because of that in a diabetic foot, definitely there would be uncontrolled diabetes, and because of the uncontrolled diabetes, you'll have complications like nephropathy, neuropathy, okay, all the pathies. So when you have nephropathy, you know that there is a degradation of the kidney for the clearance of the drug. So according to the creatinine clearance, we have to adjust the dose, which happened with piperacillin and meropenem, imipenem, etc. And failure to receive drug with one patient, because he had a resistance to all, and he only had an intermediate sensitivity to colistin, and he hadn't money to pay for the same, so there was a failure of receiving the drug. And moving on to the other DRPs that are not enlisted in the Hepler and Strand classification, as I said, the most number jumped up for inappropriate duration of drug use, which was mostly circled to prophylaxis, partially untreated indication. That is also something very interesting that we see, and which would mostly seen in surgery, I feel, because sometimes a broad spectrum is given wherein, for example, cephalosporins, and cephalosporins don't have a very good anaerobic coverage. And most of the diabetic food would be polymicrobial, and we have to, at least for an empirical treatment, we have to see for an anaerobic coverage, at least till the culture report comes up. So that was another condition seen in partially untreated indication. And inappropriate multiple drug use, wherein you give two drugs which have the similar spectrum of activity. So everyone is not aware, right, that certain drugs have anaerobic coverage also in the penicillin cephalosporin class. For example, piperacillin tazobactam has a very good anaerobic coverage, and there is a tendency to add on a metronidazole also, fearing of how well piperacillin would cover for an anaerobic coverage. But actually studies have proven that piperacillin is an excellent cover for anaerobic organisms, and which we noted, and along with piperacillin and also meropenem, we noticed the same. And lack of monitoring, which is also a problem, because as I said, we had a lot of patients with fluctuating kidney functions. So we'll have to monitor the drugs when we give amikacin, okay, or piperacillin to the patients, because it could be like a nephrotoxic drug. And if it accumulates in the body, the patient is going to stay in the hospital, not for the ailment that he was admitted for, but for something else. So monitoring is very important, which we have included in the same. And alternate dosage form. So this is wherein you have a fear of whether IV and oral would go in par, or whether there would be a sufficient penetration. So if you see into the guidelines, only ICU patients and critically ill patients should be given with IV, and it should be only for 72 hours. So that is how it is. And for the patient in the ward, it won't be much necessary. And the other thing is, when the patient has a comorbid condition like diabetes, we fear of autonomic neuropathy, wherein gastroparesis can be suspected. So that was the other reason. But we assured the surgeon, and we tried for 2-3 patients, and that was also solved. And majority of the interventions that we saw for were major, and for 49% of the cases that we identified. And I'm a very proud clinical pharmacist for this, because around 99% of the interventions that I conveyed to the surgeon were made into practice, and we could improve the antibiotic therapy for the same. Wherein I developed, which is the next step of my thesis, that the policy was developed exclusively for surgery department and under my initiative. And then we had a consensus with all the surgeons, which was approved, and it is now taken up into the hospital practice. So that is all that's happening. And thank you so much for your humble and patient listening. Thank you.
Wilson sir, please proceed with the questions.
Sir, could you please be a bit more louder, please?
Now, hello?
Yeah, I get it. Yeah, sir. Yes, sir. Please, sir.
You said 14 patients had drug-related problems, isn't it? So, what were the problems?
I mentioned all the drug-related problems, sir, in the chat. If I can share it again, I can explain. All those were the drug-related problems.
Okay. Then you said the thing is mainly it is because of improper usage of drugs. So, what could be the reason for the improper usage of drugs?
That's what I said. Improper usage is always focused on to when we find a drug-related problem. So the inappropriate use, all the drug-related problems are kind of an inappropriate use, I believe, sir. Because if it's used for a prolonged duration of time, it is an inappropriate use, which is also a drug-related problem.
Okay.
And when the dosing is not appropriate, it is again a drug-related problem, which is again an inappropriate use. So either it should be suboptimal, or it should harm the patient in both ways. If it's over or under, it's going to harm the patient. And when it's with respect to the drug, it is a drug-related problem.
Okay. Did you determine any drug concentration in the blood? You said no, you monitor. When you just talk about amikacin and all, you said no, drug monitoring is important. So did you measure the drug concentration?
No, sir. We don't have such a facility in our hospital. We'll have to go to UT, which is our sister institution. because I'm in JSS, or we'll have to send to Bangalore. We are trying to set up a lab. What I meant by lack of monitoring is the creatinine, the urea, the liver function test. So that is why I mainly mentioned amikacin, because it's a nephrotoxic drug. We have to also monitor for cholesterol. So every 3 days and before starting a nephrotoxic drug, it is very ideal to do a monitoring. So we included that also into a drug related problem.
Any other question from other evaluators?
Yeah, I'm asking on behalf of Ritulas ma'am. Name types of antibiotic stewardship interventions.
Sorry?
Name types of antibiotics stewardship interventions.
Antibiotic?
Stewardship interventions.
Stewardship interventions.
Yeah.
You have the prospective and feedback. You have the educational interventions. So do you mean that, sir?
What is the name of antibiotic steward interventions?
What we use is prospective audit and feedback, because we had to go in person, sir. So before going into what I did right now was, before going into stewardship, I had to see to the drug related problems and convince the surgeon that there is a necessity of an antibiotic stewardship rather than, burdening him with them. So they should feel that there is a necessity. And the first step was to identify the drug related problem. And further in place, we would go in with handshake stewardship program. What, if you want me to term, what practice did we do for identifying a DRP and conveying the same to the surgeon? We did a prospective audit feedback. But sir, for your kind attention, this was not a part of the stewardship. This was just a stepping stone to make them understand that stewardship is important, so that they would, when I bring the policy into picture, they would also feel that there is a necessity, because we have so many problems. Because it's all about the patient safety, that they use prolonged drugs or whatever it is. So once we convey that, even if you have drug related problems for this practice, it would be easy for them to practice antibiotic stewardship rather than just saying that a rule. So even if a kid knows why you're doing the same, rather than simply hitting him, he would do better same way. So if they understand why they're doing it, then obviously they'll be happy. So that's what, and I believe that's why I had 99% of acceptance of the interventions. And yes, sir, that's all that happened. So stewardship would be taking place, and the real picture in surgery department from July, because it's gone into the hospital policy right now. It's been approved by the director too, and we have done with the consensus. So this was just the first step for bringing it into practice.
Okay. Gurji sir, do you have any questions?
Yeah, just want to ask one question. Like in this COVID, like people are using steroid a lot.
Yeah.
What's your opinion on that?
Steroids in which context, sir? On which context do you ask me about steroids?
Case of COVID.
In case of COVID, sir, definitely we'll have to go with steroids, but we'll have to see the extent of saturation and the presentation of the patient. So even I see that mild cases are even given with steroids, and it is prolonged. So with the prolongation, there are a lot of complications. So I believe that according to the grading that we see in the CT, and with the presenting symptoms and saturation, we should take a call and taper this dose and stop as fast as possible, so that we can prevent further complications like mucormycosis and other complications, like that we have, even in type 2 diabetes patients, if you have high blood sugars. And now there's a trend, people say that after COVID you have an increase of blood sugar, and I believe that it's not because of that. And thank you for mentioning that too, so that I could say this in a platform. It's because of the steroid use. It's not because of COVID mostly that happens, because in every COVID patient you have a tendency to give a steroid, and it's it's just that we are still confused of how to manage it, and we can't blame the same, but that is a complication. So the patient can ultimately end up in type 2 diabetes mellitus also.
Thank you.
Thank you, sir. Thank you so much.
Thank you.
Yeah.
So please join at the same time. Meanwhile, Dr. Gurrama ma'am, please proceed with the vote of thanks.
Thank you, ma'am. Good evening to all on this pleasant evening to deliver my vote of thanks. We would like to express our deepest thanks to PharmaNEST'21 organized by Operant Pharmacy Education. On behalf of organizing committee, we would like to express our deepest thanks to all the evaluators, Dr. Tagore G. Singh, Associate Dean, Chitkara College of Pharmacy, Chitkara University, Punjab. Then second evaluator, Dr. Rutraj Gwar, Principal, Aishwarya College of Pharmacy, Udaipur, Rajasthan. Dr. B. Wilson, Professor and Aide, Department of Pharmaceutics, Dayananda College of Pharmacy, Bangalore, for sharing their valuable suggestion and input precious time with their interactive session. We would thank all the presenter who came from different parts of the country have joined us at the today's program. Once again, I thank each and every individuals. Thank you, sir. Now over to Vikram, sir.
Thank you, ma'am. I also thank to all the evaluators for your valuable time to PharmaNEST'21 and evaluating all the e-posters of day 8 of e-poster presentation session. Okay, thank you everyone.
Thank you, sir.